The following podcast is part of a certified educational activity titled Expanding Treatment Choices in Mesothelioma, exploring the promise of tumor treating fields and novel systemic approaches to optimize patient outcomes, featuring Drs. Charles Simone from New York Proton Center and Marjorie Zodderer from Memorial Sloan Kettering Cancer Center. Access the entire activity and complete the post-test at peerview.com/VGX860. Downloadable slides and practice aids are also available.
Hello, I'm Dr. Charles Simone, the Chief Medical Officer of the New York Proton Center and a member of the Memorial Sloan Kettering Cancer Center in the Department of Radiation Oncology. Welcome to this educational program on the expanding treatment options in mesothelioma. In a few minutes, I'll introduce my colleague, Dr. Marjorie Zodderer, a medical oncologist from Memorial Sloan Kettering Cancer Center and the co-director of the Memorial Sloan Kettering Mesothelioma Program. But now, let's begin with a look at the therapeutic management of mesothelioma. We know that there are approximately 3,000 patients diagnosed each year with mesothelioma in the United States, and it's strongly linked to asbestos exposure. The most common type of mesothelioma is malignant pleural mesothelioma, which represents about 60% of all patients diagnosed. Currently, there's no consensus treatment options for mesothelioma. Since it's a relatively rare disease with unfortunately poor outcomes, there's not great consensus on what treatments patients should pursue. Patients that have disease confined to one hemithorax with limited or no metastatic disease and nodal metastasis, good performance status, those patients can and often are considered for surgery provided they can undergo a gross macroscopic resection. And that can involve an extended pleurectomy, decortication, or it can involve an extrapleural pneumonectomy with or without intraoperative adjuvant treatments that we'll talk about. And then these patients are also recommended to receive chemotherapy either in the neoadjuvant or adjuvant setting. Unfortunately, only about 15 to 20% of patients are candidates for surgical resection, either because of age or comorbidities or more advanced disease than what we described. For everyone else, the current options for patients really have not changed too much over the last 3 decades, and there have been 2 breakthroughs since then. The first came in 2003 when we found that the addition of pemetrexed to cisplatin can increase response rates and improve overall survival for mesothelioma patients. Patients who are either in the palliative setting or otherwise cannot tolerate cisplatin often are treated with pemetrexed and carboplatin in this setting. More recently, in 2016, a study was published showing that the addition of Bevacizumab to cisplatin and pemetrexed can further improve survival. All of that is in first line, but unfortunately, we don't have a standard treatment approach for the second line setting. And many exciting treatments that we'll talk about today are potential candidates for future standard treatments in the second line. One big breakthrough that happened this year alone in 2019 was that the FDA approved TTFields in combination with pemetrexed and platinum-based chemotherapy as a humanitarian device exemption for the first-line treatment of unresectable, locally advanced, or metastatic mesothelioma. And we'll talk about this much more today. But certainly when available, we strongly encourage clinical trials to be considered. Let's take a look at TTFields, the latest therapy approved for mesothelioma. TTFields are a non-invasive, antimitotic, local regional cancer treatment. They involve alternating electric fields delivered through a portable medical device that we'll show you, and that's tuned to a specific frequency to disrupt solid tumor cancer cell division. As we mentioned, it's now FDA approved for mesothelioma as a humanitarian device exemption. This is really the first breakthrough for mesothelioma that we've seen in about 15 years. And this is building on TTF's experience with GBMs. It's been approved there and relatively widely utilized both in the initial and the recurrent setting for patients with glioblastoma multiforme. And we know that in addition to improving survival, it can actually preserve quality of life for newly diagnosed GBM patients. So how does TTF work? Well, it disrupts mitosis in multiple different ways, and it's multi-mechanism. The first thing that we'll look at is its effect on metaphase. For all of its actions, we know that it works through electric fields, and it provides a constant uniform electric field with changes in the direction of opposite polarity. So here you can see on the slide, it generates an alternating electric field, and changes move back and forth and diodes rotate. And what effect does that have on metaphase? Well, because we have this alternating electric field, we can see disrupt alignment of highly polarized tubulin subunits, as well as disruption of microtubule spindle formation during mitosis, and that ultimately leads to the cell undergoing apoptosis. The other effect that TTF has is on telophase. Similarly, using the non-uniform and converging electric fields, we're going to see concentrated electric fields intensely at smaller electrodes and charges and dipoles moving towards the area of highest electric field intensity. And what that does with the non-uniform electric fields is it results in a change in the cell shape during telophase that can cause a non-union electric field. Also, polar components then move to cleavage furrows, and ultimately cells cannot divide properly, and that also will lead to apoptosis and tumor cell death. So in summary, TTFs are an anti-mitotic therapy, and living cells, both normal tissues as well as mesothelioma cancer cells, contain ions and polar or charged molecules. Those charged particles and dipoles can then influence by electric fields. Since TTF uses alternating electric fields, it can disrupt charged particles during mitosis, which can then lead to cell death in dividing cancer cells, but actually can spare quiescent cells, and we'll talk more about that. Here you can see the different phases of the cell cycle from the resting state to G1, also to S, the DNA synthesis. But as cells move into mitosis, you can see that this is where it has an effect, and when the tumor cell goes to divide into new cells, we're seeing apoptotic cell death. One thing that's important to know is that TTF fields are frequency tuned to cancer cell histologies, and that's really where we see the differential effect between the effect on tumor cells and on normal tissues. So for instance, the effect on cells are frequency specific and inversely related to cell size. So here you can see a variety of cancer cells, each with a different frequency that's most optimized to TTF cell killing. Mesothelioma has a peak at 150 kilohertz. How is TTF delivered? Well, it's a portable, non-invasive device that provides localized treatment. TTF is a low intensity, generally on the order of 1 to 3 volts per centimeter. Intermediate frequency, we mentioned 150 kilohertz, alternating electric field delivered in 2 directions. It's a single user transducer array, and it's applied directly to the chest, or the area deep to which we see cancer and mesothelioma in this case. And patients put this device on, and it's positioned through transducers to have individualized treatment for patients. So depending on where their disease is in the chest, that's where the focus of this transducer will be applied. This therapy is a new modality for cancer and a new strategy for treating malignant pleural mesothelioma. In the next segment, we will take a look at the clinical evidence of TTFields in mesothelioma. We will also go over patient case scenarios to highlight optimal management with TTFields. Welcome back. I'm pleased to introduce my colleague, Dr. Marjorie Zauter from Memorial Sloan Kettering, as we discuss the clinical evidence of the new treatment modality for mesothelioma. Marjorie, welcome.
Thank you, Chuck. It's great to be here.
Okay, diving right into the evidence, we'll discuss the rationale for the use of TTFields in mesothelioma. We know that there currently are limited treatment options for this disease. Chemotherapy response rates are lower than other thoracic malignancies, and TTF can directly cause tumor kill and allow for increased efficacy of chemotherapy in combination with TTF. Mesothelioma is a relatively fast-growing tumor that may have rapid tumor death from TTF when cells attempt to divide, since it's an anti-mitotic agent. Now, let's discuss the results from the pivotal phase 2 STELLAR trial, which was the backbone for the approval of TTFields in combination with chemotherapy in the first-line setting. This was first presented at the International Association for the Study of Lung Cancer World Conference on Lung Cancer in late 2018, and this was the final results of a phase 2 trial of TTFields with chemotherapy for first-line treatment of malignant pleural mesothelioma. So in this study, 80 patients were evaluated, and the primary endpoint was overall survival, with a predicted improvement in overall survival compared to historical controls. Key inclusion criteria included pathologic evidence of unresectable mesothelioma, at least one measurable lesion, and an ECOG performance status of 0 or 1. Patients then received TTFields, as we mentioned, at 150 kilohertz, and was recommended to be treated at least 18 hours per day, in conjunction with pemetrexed and platinum-based chemotherapy for 6 cycles. Key exclusionary criteria were candidates for surgery, significant comorbidities, and poor performance status, as well as an implanted electronic medical device. Following treatment with TTFields and chemotherapy, patients continued on TTFields alone until disease progression. They were followed for overall survival, which was the primary endpoint, with secondary endpoints of response rate, progression-free survival, and safety. Looking at the patient characteristics, patient's median age was 67 years. Most patients were male, and over half of the patients had an ECOG performance status of 0. 2/3 of the patients had epithelial histology, with the remainder of patients having sarcomatoid or biphasic histology most commonly, or otherwise unspecified histology. Patients received their TTFields and a median of 6 cycles of chemotherapy, and it's important to note that 2/3 of the patients actually received carboplatin-based chemotherapy in contrast to cisplatin-based chemotherapy. Looking at the results, the median overall survival of the study, 18 months, with a 1-year overall survival rate of 62%. Median overall survival was over 21 months in the entire cohort, and the median progression-free survival was nearly 8 months. We saw response rates in over 40% of patients treated on this study. And this is of note that the overall survival compared to historical controls was met with a hazard ratio of 0.663. Looking a little deeper at the radiographic response patterns in the study, as I mentioned, over 40% of patients responded. All of those responses were partial responses. But the clinical benefit in the study was over 97%, and that included partial responses as well as patients with stable disease. The median time between treatment start and partial response was 1.8 months, with a range of generally 1.5 to 4.5 months. All patients presenting with a partial response did have continuous reduction in the total sum of lesion diameter. The median duration of response of note was 5.7 months, with a range of some patients extending to beyond a year. So it's important to keep in mind that while these response rates are similar to ones previously reported with cytotoxic chemotherapy alone, our current standard of care, we did see that the responses lasted longer with the addition of TTFields in this study. Looking at the safety of the phase 2 STELLAR trial, specifically at the grade 3 or higher toxicities, about 1 in 4 patients had at least one adverse event. You can see on the left that most of those toxicities were expected and related to chemotherapy, with a handful of toxicities related specifically to TTF. Looking at that more specifically, about 46% of patients had TTF-related skin toxicity, 5% of which had grade 3 skin toxicity, and that was generally in the form of a rash. There was resolution after treatment with typically topical corticosteroids or a short treatment break in a handful of patients. But important to note, there were no serious adverse events related to TTFields themselves. The median compliance was a little bit shorter than expected, but still an impressive 16.3 hours per day that patients wear the device. There was no increase in systemic toxicity with TTFields, and the only adverse events seen specifically related to TTF was skin irritation beneath the transducer arrays.
Chuck, this data is really provocative. How does it compare to other existing standard therapies in mesothelioma?
Well, here you can see a summary of recent studies in mesothelioma. When we compare the STELLAR trial, in general, there was a little bit higher proportion of males and a little bit lower proportion of epithelial histologies, we know both of which are associated with a poor prognosis. Despite that, the median overall survival in the cohort was 18 months. When specifically looking at patients with epithelial histology, it was over 20 months. And that does compare favorably to the other studies that are depicted here.
How do you pick the right patients to receive this type of treatment?
Well, we know that TTF can be used in patients with all histologies as well as all performance statuses, but it seems based on this data that there was a disproportionate response, particularly in the biphasic and sarcomatoid patients. We know that 20% of sarcomatoid patients in the STELLAR trial had responses, and that really is higher than we would have expected with chemotherapy alone. Another group to really consider TTF for is patients with more limited performance statuses. While we do encourage clinical trial enrollment for this malignancy, oftentimes patients with limited performance status would not be eligible for a clinical trial. Patients that are aligned to be aggressive in their treatment may benefit from the addition of TTF to chemotherapy. There's always challenges when integrating new modalities into practice. Here I've summarized some important points on patient education and device training. First, training on the device. It is important to know that device support specialists and nurses can assist patients and come to their homes. Patients receive a comprehensive initial visit that discusses array placement, the use of the equipment, and skin care in the event of any skin toxicities. Thereafter, they have monthly visits where they download their compliance reports. They show those to the patients of how many hours per day they're receiving their therapy and encourage maximal compliance. They also have interval phone discussions as well as in-person support as needed for any issues that may arise. Also keep in mind that patient education for this new technology is critical. Patient compliance is also critical, and we know that the longer patients wear the device, in general, we see better response rates. That also requires continuous monitoring of the device. So Marjorie, what other practical considerations do you consider when implementing a new treatment for a disease?
That's a great question. One of the most important things I consider is what a particular patient's priorities and goals for their care are. And what's important to think about, particularly with TTF, is the wearing of the device and how that fits into a patient's daily routine.
And that's a great point. Speaking of integrating new treatments, there are several other local modalities that can be considered for mesothelioma that may be promising in the future. Just like TTF is a localized therapy, local therapies during surgery may also be of benefit. Some things that are actively being tested are photodynamic therapy, the use of this treatment as an adjuvant to surgery, as well as intraoperative chemotherapy, either in patients who are receiving surgery in the adjuvant setting or in the definitive setting for patients not eligible for surgery. Highly conformal radiation techniques may also be a benefit to select patients, and those really would focus on the most advanced radiation known today, intensity modulated radiation therapy, or proton therapy with intensity modulated proton therapy. So in conclusion, TTF can achieve prolonged survival for malignant pleural mesothelioma with minimal toxicity, and it is now an approved treatment option for patients. Additional clinical trials assessing the other emerging treatment paradigms of mesothelioma are welcome, and clinical studies examining the impact of combining TTF with immunotherapy or with radiation therapy may further provide evidence of this synergy of a combination for this difficult malignancy. Now, let's take a look at a patient case that will illustrate this data into clinical practice. So recently, I saw a 74-year-old male with malignant pleural mesothelioma, but he had several known adverse risk factors. First, he was male. Second, he had sarcomatoid histology. Third, he had nodal metastases, including posterior intercostal lymph nodes, and he also had a very large tumor volume. Beyond that, he wasn't of the best shape from a performance status standpoint. He was a borderline ECOG 2 performance status, and he had significant weight loss in the last 2 months. The patient is compliant and motivated to be aggressive with treatment. So this is the kind of patient we could consider a combination of TTF and chemotherapy. He's not a surgical candidate because of the sarcomatoid histology, and he's also not a great clinical trial candidate because of the limited performance status and significant weight loss. What do you think?
I think that's exactly right. This is a patient who typically wouldn't be eligible for an ongoing clinical trial.
What would you do if this patient had epithelial histology instead?
That's a tough question. With epithelioid histology, we expect a bit better response from chemotherapy. And certainly in those patients, I consider the use of a triplet approach with a platinum agent, pemetrexed, and bevacizumab. But in someone with weight loss, poor performance status, that might be too toxic of a chemotherapy regimen. So that might also be the type of patient where we would give 2 cytotoxic agents, carboplatin and pemetrexed, and could consider the addition of TTF.
So if this same patient had a better performance status and didn't have as much weight loss, given his sarcoma histology, or even if he was an epithelial patient, what treatments would you recommend? Are there clinical trials that you would encourage him to enroll in?
Sure. For sarcomatoid histology, there's an ongoing clinical trial where patients receive cisplatin and pemetrexed and are randomized to receive ADI-PEG, which is an arginine synthetase inhibitor. We think that that agent's particularly effective in sarcomatoid histology. For the epithelioid patients with good performance status, most of the trials ongoing for that patient population revolve around combination of chemotherapy with immunotherapy or chemotherapy, anti-angiogenic treatment, along with immunotherapy.
So we discussed that TTF could be considered in patients with both poor and good performance status, both epithelial and non-epithelioid histologies, and younger and older patients, particularly those specifically who are medically inoperable or surgically inoperable. There may be some patients who could particularly benefit, including those with poorer histologies like sarcomatoid or biphasic, or more limited performance statuses. The previous patient we did treat with TTFields, and he actually did very well with treatment. He got through the treatment with no TTF-specific toxicity, but he did develop some skin irritation and erythema underneath the pads. When patients are started on TTF therapy, education is certainly very important. They need counseling on the device compliance, as well as how to change the transducers, how often to change the transducers, and then also skin care strategies. It's important that the patients are seen regularly, and that could include visits at home with their device support specialists or nurses, but they should also continue to see their oncology team throughout treatment. And both sets of groups can monitor for adverse effects of both TTF as well as chemotherapy if they're receiving chemotherapy at that time. They also should be trained to look for dermatologic effects of the treatment and talk about prophylactic strategies that can be used to help with treatment-related adverse events. So Marjorie, for a patient like ours who develops skin toxicity, what kind of treatments would you recommend?
Well, I would consider what type of skin toxicity it is, and I would really take advantage of the 6 hours off the device to apply different topical therapies depending on whether the skin was irritated or broken down. The other thing is I tend to work very closely with a dermatologist specifically to help manage treatment-related toxicities.
Okay, thank you, Marjorie, for a great discussion. In the next section, Marjorie is going to review the standard of care and the evolving role of novel systemic approaches for mesothelioma. Welcome back. I'm here with my co-presenter, Dr. Marjorie Zotter, who will review novel systemic therapies being integrated with mesothelioma. Marjorie, please take it away.
Thank you, Chuck. While Chuck provided us with a great introduction into standard treatments for mesothelioma, I think it's time for us to take a deep dive into some of the evidence. Now we're going to take a look at some standard therapies in mesothelioma, as well as explore ongoing clinical trials with novel agents in this disease. There's certainly a lot of activity with ongoing clinical trials looking to exploit our burgeoning understanding of the biology of mesothelioma, and these approaches hold a lot of promise for improving treatments in these patients. Malignant pleural mesothelioma has its own NCCN guidelines. I'm going to take you through some of the data that we have regarding existing treatments for this disease. In the landmark Phase 3 EMPHACIS trial, patients with unresectable malignant pleural mesothelioma were randomized to receive cisplatin alone or cisplatin in combination with pemetrexed. In this study, we saw a modest improvement in survival with pemetrexed and cisplatin compared to cisplatin of a little less than 3 months, and this statistically significant difference in survival led to the FDA approval of pemetrexed and cisplatin, which has been the standard treatment approach for mesothelioma since its approval in 2004. Subsequently, we've learned about the addition of angiogenic inhibitors to this treatment paradigm. Here you can see the schema for the MAPS trial. In this study, patients with unresectable malignant pleural mesothelioma were randomized to receive either cisplatin and pemetrexed or cisplatin, pemetrexed, and bevacizumab. You can see here the results and survival curves. The addition of bevacizumab improved overall survival from 16.1 months to 18.8 months, and this was a statistically significant finding. While bevacizumab has not been FDA approved, it has been added to the NCCN guidelines and is considered a standard agent in the treatment of this disease. There are no FDA approved second-line agents to treat malignant pleural mesothelioma. Responses with the existing active agents are uncommon in patients previously treated with pemetrexed. Vinorelbine and gemcitabine are the most commonly used agents, and their response rates are typically less than 10% in the post-pemetrexed treatment setting.
Thanks for that great review. Now in oncology, with lung cancer specifically, we talk about checkpoint inhibitors quite a bit, and many of which are FDA approved for non-small cell lung cancer. Do they work for mesothelioma?
Yes, there's a lot of interest in these agents for mesothelioma and some interesting data from early phase clinical trials that show that these agents are active. Checkpoint inhibitors work by disinhibiting the cancer's suppression of the immune system. And here you can see some of the identified stimulating and blocking agents that are known, many of which have agents in development or already FDA approved for treating a particular type of cancer. And of course, this is not a complete list. With respect to mesothelioma, there have been several important trials. First, there was a phase 2 randomized trial in which patients with previously treated pleural as well as peritoneal mesothelioma were randomized in a 2-to-1 fashion to receive either tremelimumab or placebo. Unfortunately, this trial demonstrated no survival benefit. Subsequently, pembrolizumab was studied in a phase 1b expansion trial. In this study, patients with mesothelioma that was PD-L1 positive greater than 1% were able to receive single-agent therapy with pembrolizumab. You can see here in the waterfall plot that the response rate was 28%, and certainly there were many patients with prolonged stable disease. Similarly, nivolumab with and without ipilimumab has been studied in mesothelioma. Again, in previously treated patients, they were able to receive either nivolumab or nivolumab and ipilimumab. You can see the waterfall plot for nivolumab on the top and the combination treatment below. Response rate was certainly improved with the combination, but toxicity was also substantially greater. The results of both of these trials have led to the inclusion of all three of these agents in the NCCN guideline as treatment options for second line and beyond in malignant pleural mesothelioma. However, no definitive randomized phase 3 trial has been completed in the second line setting with any of these agents. There is, however, a frontline trial with nivolumab and ipilimumab versus chemotherapy in chemotherapy-naive patients. In this study, patients with unresectable chemotherapy-naive malignant pleural mesothelioma and performance status of 0 to 1, they were randomized to receive either standard chemotherapy with cisplatin or carboplatin and pemetrexed or nivolumab plus ipilimumab. This study has fully accrued, and we're waiting for the results to mature so that we can know whether our frontline therapy should change. Here you can see the schematic of the DREAM trial. In this study, patients without prior therapy receive cisplatin and pemetrexed in combination with durvalumab, followed by durvalumab maintenance. The primary endpoint of this study is the progression-free survival at 6 months. The preliminary results of this trial were presented at ASCO last year, and here you can see the waterfall plot. What we see from this is that the response rate from the triplet of pemetrexed, cisplatin, and durvalumab is better than what we would anticipate from the chemotherapy alone. These data are certainly provocative, and we look forward to seeing more data about this study and also the ongoing PRECOG trial of the same combination being conducted here in the United States. There are several trials with checkpoint inhibitors that have either recently completed and we're awaiting results or that are still underway. In addition to the nivolumab plus ipilimumab versus chemotherapy in the frontline setting, and the DREAM trial and the PRECOG trial that I mentioned, there are several other studies underway. There's a clinical trial ongoing of nivolumab versus placebo in patients who have been previously treated. This is the CONFIRM trial. In BEAT Meso, newly diagnosed patients can receive cisplatin and pemetrexed along with bevacizumab and atezolizumab, and this certainly mimics the structure of treatment for non-small cell lung cancer. There's also a clinical trial exploring pembrolizumab in the recurrent setting compared to gemcitabine and vinorelbine. And finally, there's an ongoing study that I alluded to previously of immunotherapy in combination with cisplatin and pemetrexed as an initial therapy to treat this disease. I think we're all looking forward eagerly to the results of some of these studies so that we can better inform our choices in both the first-line and second-line setting.
That's interesting. What other agents are being used for mesothelioma?
A lot of agents are being studied that exploit the underlying molecular alterations in mesothelioma. Let's take a look. The recent advances in next-generation sequencing have recently come to fruition in mesothelioma, with several series reporting the molecular alterations that are common in this disease, including one series from the TCGA network. One common alteration in mesothelioma is in the NF2 pathway. When NF2 is mutated or absent, PI3 kinase and mTOR signaling proceeds unchecked. This has led to the exploration and development of PI3 kinase and mTOR inhibitors in mesothelioma. One agent, GDC-0980, generated substantial responses in a small fraction of patients treated in a phase 1 expansion cohort in mesothelioma. It's important to note that there seemed to be no correlation between response and PIK3CA or NF2 loss. Another PI3 kinase mTOR inhibitor has also been studied in mesothelioma and had similar results with a modest response rate of about 5%. Notably, there were several patients with prolonged stable disease. Certainly, in a single-arm study like this, it's difficult to interpret these results, but it's important to note that this was a relatively typical patient population for a second-line agent setting. Another way to exploit NF2 is to look at its function in the cellular nucleus, and we can do this by starting to target the Cullen ring that forms. In this setting, Mesothelin, the protein encoded by NF2, suppresses a downstream signaling cascade that leads to the expression of oncogenic genes. By disrupting the formation of the Cullen ring in this process, we can hopefully abrogate the unchecked signaling that happens when Mesothelin is absent or mutated. One way of disrupting Cullen ring formation is with a netylating 8 enzyme inhibitor. There is one such compound in development, and that's pevonedistat. There's currently a phase 1/2 clinical trial ongoing of pevonedistat in previously treated mesothelioma. In the phase 1 portion, pevonedistat is being studied in combination with cisplatin and pemetrexed. In the phase 2 portion, pevonedistat is being given as a single agent in patients who have NF2 altered mesothelioma. BAP1 mutations are also very common in mesothelioma, but targeting this alteration is less clear, and that may be due in part to the multiple functions. BAP1 clearly has a role in double-strand DNA break repair, epigenetic modifications, as well as transcription factor regulation. One active area of exploration is the epigenetic activity of BAP1. We know when BAP1 is lost that simultaneous knockout of EZH2 can rescue BAP1. EZH2 is the only known methylator of H3K27 trimethyl, therefore making EZH2 an interesting potential target in BAP1 mutant mesothelioma. This led to the clinical trial of an EZH2 inhibitor, tazemetostat, in BAP1 deficient mesothelioma. What you can see here is that the response rate with this compound in BAP1 deficient mesothelioma was modest, but that a substantial proportion of patients achieved durable, stable disease. And the study was positive with a disease control rate at 12 weeks of 47% in the total cohort and 23% at 24 weeks. Another active avenue of exploration revolves around targeting mesothelin. Mesothelin is a surface glycoprotein. Its expression is high on cancer cells and low on normal cells, and several approaches are underway to exploit this as a drug target, including adoptive T-cell therapy with chimeric antigen receptors, tumor vaccines, recombinant immunotoxins, chimeric monoclonal antibodies, and antibody-drug conjugates. Here you can see a brief schematic of chimeric antigen receptor T-cell therapy targeting mesothelin. Cells are taken from a patient and engineered in the lab to attack mesothelin and then given back intrapleurally to patients. Other trials with mesothelin-directed CARs are ongoing, and there's also an antibody-drug conjugate trial underway. There are certainly many other clinical trials ongoing in this disease, some of which target the molecular alterations I've already mentioned. Some notable highlights are the PARP inhibitors olaparib and niraparib that are particularly interesting in BAP1 deficient disease or disease where there may be other DNA repair mechanism alterations. ADI-PEG, which is an arginine synthetase inhibitor, is being studied in combination with cisplatin and pemetrexed, and this is felt to be particularly effective in biphasic or sarcomatoid mesothelioma. Immunotherapy is being explored in combination with anti-angiogenic agents as well as with radiation techniques. And certainly novel immunotherapy drugs targeting other checkpoint inhibitors besides PD-1, PD-L1, and CTLA-4 are under study. Okay, so I just covered a lot of data. Chuck, perhaps we should take a look at a patient case to clarify the applications of this information.
That sounds great.
So a patient I recently saw was a 64-year-old gentleman with stage 3B epithelioid mesothelioma. He had unresectable disease because of several sites of chest wall invasion. Otherwise, but for some chest wall pain at these areas, he has a good performance status and is otherwise well. He also doesn't have any weight loss leading into this diagnosis and consultation. He very strongly feels that he should have the most aggressive treatment possible and is open to standard options as well as experimental approaches. So I thought about enrolling him on a clinical trial.
That's a great approach. You've just talked about a lot of different trials. Which one would you think about for him?
I think there are a few different options. Certainly, there's a lot of focus and interest lately on chemotherapy, immunotherapy combinations, and there are a couple options to pick from, some including and some without anti-angiogenic agents in addition.
Now, if this patient wasn't interested in a clinical trial, what would you recommend?
Well, I think the two options to choose from would be cisplatin pemetrexed with bevacizumab or cisplatin and pemetrexed with the tumor treating fields.
So how would you pick between those two?
That's a tough question to answer. A lot of these decisions come down to a really detailed discussion with patients about the existing data, as well as understanding tumor treating fields, what the data do show, and what the toxicity profile might be. I find that patients tend to have a very strong feeling one way or the other about how they want their treatment to unfold.
Well, that's a great point. Thank you very much for your discussion, both of this patient's case, as well as for reviewing all of the exciting data and new trials available for mesothelioma. And thank you, viewers, for joining us today. We've seen a lot of progress in mesothelioma in the past few years, and the ongoing studies may allow for an even greater improvement in the outcomes for our mesothelioma patients in the coming years.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/VGX860. This activity is supported by an educational grant from NovoCure. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.